Okay, hi everybody. I'm Dr. Waner, and this is.
Hi, I'm Teresa. Oh,
Go-
nice to see you.
Nice to see you. We're very happy to be here and to be answering your questions. Um, do you want to start with some of
Yeah,
the
so
questions?
I'll be asking the questions. If somebody can give me, hey Cassidy, you're my bigger. Can you
Don't
give
say
me a
that.
heads up to say that you can hear me from here? Okay, so we're going to start with some questions that were submitted to us online in the registration form. My mom asks about an ulcerated hemangioma. She's got a 7-month-old ulcerated hemangioma on the forearm, currently on propranolol, changing the dressing every day. Her question is, how long does an ulcerated hemangioma take to heal completely, and is there anything else they can do to help the process?
Yeah, I can answer this. First of all, I think you need to know that ulcerated hemangiomas are enormously painful. We believe that the pain from the ulcerated hemangioma is greater than the pain from just a simple ulcer or scrape somewhere in the body. And that's probably related to some chemicals released by the ulcerated hemangioma. So they are extremely painful. And if they're in the diaper area, they're going to be even more painful. Now, there are two types of hemangiomas. There are focal and segmental. Focal are the lumps and bumps that grow wherever they grow on the face, whereas segmental are these
I can
diffuse,
see your arm.
spread out hemangiomas. I can see it. Is it?
Okay.
Segmental are these
Is that
diffuse,
better?
spread out hemangiomas. And both of them can ulcerate, but segmental hemangiomas are more inclined to ulcerate. And when they do, they can be very, very difficult to treat. Unfortunately, there is no known treatment that promotes healing for hemangiomas. All we can do is keep applying dressings, changing dressings as is necessary. We do treat hemangiomas with propranolol, but during ulceration, the dosage of propranolol is reduced. And the reason for this is we think that propranolol at full dosage may promote more ulceration. We're not sure, this has never been proven. So these children are on a reduced dosage, and how long will it take? This depends on how much is ulcerated. Now, if there is a focal hemangioma that's ulcerated, we can remove it surgically, and this makes a tremendous difference for the child, depending obviously on where it is and how big the hemangioma is. But I have removed several ulcerated hemangiomas, and this has made an enormous difference. If it is a segmental hemangioma that's ulcerated, it's much more difficult to deal with, and typically we do not remove these because this can result in worse ulceration. How long will it take to heal? This depends on how big the ulceration is, but it can take months. And so, unfortunately, I don't have any pearls of wisdom or any way of treating these and promoting rapid healing, but it can take months to heal. And the other thing you should know is whenever an hemangioma has ulcerated, it will leave a scar. It's almost invariable, and at some point this will have to be treated.
I think just to add to that, sometimes Dr. Wainer said we lower the dose of propranolol for a segmental hemangioma and for an ulcerated hemangioma. The other thing we do sometimes is we add steroids. So steroids used to be the first line years ago before propranolol came into the scene. And for an ulcerated segmental hemangioma, we might drop the dose of propranolol and add a small dose of steroids. And sometimes we go back and forth with that. Steroids have some side effects, like it can retard growth, slow down growth, all sorts of problems, which is why we don't like to have the kids on steroids for too long. But that is an option. Ulceration also can cause infection, can cause systemic infection, so it's really important to stay on top of it. And there are other medications, other ointments that can be added to speed up the healing process, some of which require a lot of insurance back and forth. But there are other options for local wound care in that scenario.
So we have another question from Alexandra about a hemangioma. She's asking for advice on propranolol treatment. What are the risks, what are the opportunities, and what to watch out for when babies are under a year old? And also, are they congenital?
Okay, so first question, are hemangiomas congenital? They are congenital, meaning that the child can be born with a hemangioma. But are they inherited? And the answer is, as far as we know, no. 1 in 10 children will have a hemangioma. Most of them are very small and inconsequential, but a percentage of those will have a severe clinical hemangioma. But as far as we know, they are not inherited. Now, propranolol. Propranolol has become the treatment of choice for hemangiomas, certainly the first line of therapy. How do we treat hemangiomas? If the hemangioma is inconsequential, we can treat it by just watching it and not providing any treatment if this is not necessary. There is a topical uh, treatment called timolol, which is a topical form of propranolol. And if the hemangioma is very thin and on the surface only, and there's no deeper component, then timolol can be applied. If indeed the hemangioma is deeper and thicker, and we do decide to treat it, we can treat it with propranolol. There are side effects. There are major and minor side effects from propranolol. The two major ones that we always think about are hypoglycemia, meaning a drop in the blood sugar level, and asthma, worsening of the asthma. So in order to prevent hypoglycemia, we always insist that the dose is given during or after a feed, never on an empty stomach. We tell mothers that if the child is ill and not feeding well, you can skip one or many doses and then pick up again after the child is well again. So never give it on an empty stomach. And obviously, if the child does have asthma, any underlying asthma, this can make it worse. There are a number of minor side effects, sleep disturbances, cold hands, etc., etc. These are not that significant. Now, one of the questions that's often posed is, can this have some sort of long-term effect on the child? All of the data to date suggests no. However, we know that propranolol does cross the blood-brain barrier. In other words, it does cross over into the blood supply to the brain, and we know that in older patients it can cause short-term memory loss. Whether or not this translates into any problem later on or not, so far there is no evidence. However, I must say that there was a paper published about a year or so ago in which they looked at the long-term side effects, and it was felt that in males, in male children, there could potentially be some long-term side effect to propranolol. They felt that male children could potentially have a slightly lower IQ. However, a subsequent paper refuted this. So it's out there. For some reason, females' brains are much more plastic and much more pliable, and so they're less inclined to have problems. Now, for this reason, people in Canada use nadolol, which crosses the blood-brain
Does not.
barrier. Well, it does
Oh, yeah.
cross, but to a much
Oh,
lesser extent.
yeah.
And according to this paper, that did not make much of a difference. So, there are a lot of questions out there. But propranolol is effective, and if it's indicated, it should be used.
So we have another question from Elizabeth. Um, I guess, I'm sorry, somebody just asked a question regarding that. Where can they find that paper?
I can post it.
Jessica
Yeah,
Waner.
yeah. I can post it online. In fact, I do have it somewhere around here
We
because I
can
was.
we can
Yeah,
post it
We
w-
can
afterwards.
post it
we'll post it
afterwards.
online. We'll post it on. In fact, we'll send it to the person. It's Jessica. We'll
Yeah.
send it to you.
No. Okay. So Elizabeth, her question. She's got a 2-year-old with a hemangioma that was post ulceration. Since being off hemangial, she's had new swelling. What are her treatment options and advice?
Okay.
How, first of all, how old is the child?
She says 2-year-old.
2 years.
The child is 2 years old,
Maybe
and
a
it
segmental.
Yeah.
reads that it was ulcerated at one point.
And where is it? Does it
It
say?
does not say.
Okay. And so she's come off, she was on the hemangial till age 2. She just came off and there was some rebound,
She calls it new swelling.
new swelling. So I guess I'd want to see how big is it, where is the hemangioma. If it's still growing at age 2 and there's rebound after you've stopped the medication, then this hemangioma is segmental. Dr.
Likely.
Waner at the beginning talked about focal hemangiomas, which are like the cherries, and segmental hemangiomas, which are the ones that are more spread out. So it sounds like this would be segmental because focal hemangiomas only grow for 8 to 10 months. In which case, you would probably go back onto the hemangial and would continue and then try another withdrawal maybe in another month or two. But I would like to see, we would want to see where is it deep, is it uh, compound, meaning deep with skin
Hmm.
involvement, uh, where is it and how big is it and how is it affecting the anatomy?
Yeah, but I think the most important is that it's probably a segmental hemangioma, and the growth period for segmental hemangiomas can be a lot longer, typically a year to 18 months. But we've seen segmental
2,
hemangiomas
3, yeah.
grow for several years. I've seen one grow for up to 5 years. So that may be the reason. So what do? You go back on propranolol, and I would wait another 2 or 3 months
Yeah,
and
and
then
then
taper off and see what happens. You keep playing cat and mouse with the hemangioma and propranolol until it stops
yeah.
proliferating.
Or you instead of,
Another treatment.
yeah,
Yeah.
instead of every month increasing the dose by weight, you just hold off on those increases, and that sort of is its automatic taper
Taper.
each month.
So we just got a question from Ivana. She's just asking, do you treat adults as well as children?
Yes, we do. Both of us do. Vascular malformations are often in adults, and we treat both adults and children.
And Carrie has a question. She says, is it safe to operate on a deep hemangioma on her 1-year-old daughter's forehead with a feeder vein?
Um, uh, every hemangioma is going to have a feeder artery and a draining vein. These are common, and the answer is yes. If the surgeon is experienced, the first thing we do is we lift the skin up. We look for the blood supply, the arteries that supply blood, and the veins that drain blood from the hemangioma. We tie these off and remove them. So the answer is yes, it is safe.
Yeah, and when parents ask us, oh, how much bleeding will there be? Will it be very bloody? Do I have to donate blood? That's absolutely not the case. It's pretty much bloodless. You might lose a teaspoon max, but not even that. Usually, it's a very clean plane that we, as soon as we lift the skin, it's almost like I liken it to the orange rind You've peeled the peel, and it's that white stuff that you just sort of go in, and then the hemangioma comes out very nicely, and then we close. So bloodless.
And the other thing is, an often asked question is, when is the best time to operate? Is it possible to operate early, within the first year of life? And the answer is yes. If we're dealing with a focal hemangioma that's ulcerated, I can remove it, and it will not recur if I remove the entire hemangioma. If I do not remove the entire hemangioma, what's left behind will continue to do whatever hemangiomas do. But the time to operate is when it's necessary. If there's an eyelid hemangioma, one of the things Dr. Owen I found, to our absolute alarm, was that 10% of children with eyelid hemangiomas were already blind in that eye by the time they were referred to us. Clearly, this is a huge problem, an unrecognized problem. So the treatment for eyelid hemangiomas should be much more aggressive. And yes, it is possible to operate at any age. The answer to that question is we operate when it's necessary. If the hemangioma is still proliferating, it's preferable to remove the entire lesion. That way it will not recur.
So, along those lines, we have a few questions. I think you answered some. Some are asking, is there recurrence after hemangioma excised? And do you need to continue medication after the hemangioma has been removed?
Yeah, I can
So,
answer.
as Dr. Waner said, if it's a focal cherry hemangioma, we go in and do surgery. Even if it's proliferating, if we remove the whole thing, no, it will not recur. If it's a situation, for example, in the orbit, some of the hemangioma is growing out of the lacrimal gland, sits up here, or inside the eyelid, then we may go in and trim a portion of the lacrimal gland so it's not obstructing or pushing on the globe anymore. And in that case, where it's still in its growth phase, still in that first 8 to 10 months for a focal, or 2 to 3 years for a segmental, the child will still remain on the propranolol after the surgery. So it depends always on the growth phase, the type of hemangioma, the growth phase of the hemangioma, and the location of the hemangioma. The next question.
Next question is, what is the rate of involution? Do all hemangiomas involute? And are they gone by the age of 1?
Okay, very few hemangiomas are gone by the age of 1. So the answer to that is all hemangiomas involute. Involution simply means shrink. So all hemangiomas will grow, stop growing, and then shrink. As I mentioned, focal hemangiomas will grow for up to 6, 7, 8, 9 months, somewhere around there, plateau, and start to shrink. Segmental hemangiomas can grow for longer, and as we mentioned, much longer periods in some cases, but they all eventually stop growing and shrink. So does shrink mean it will go away completely? According to literature and according to research, about 50% of hemangiomas will involute satisfactorily. 50% will not. So the rapid involuters, the ones that stop growing quickly, will very rapidly shrink and would most likely leave a good result. Whereas the slow involuters are more likely to leave problems behind. But remember, very few hemangiomas will be gone by 1. We typically say that the involution process is done by about 3.5 to 5 years. Beyond that, there's very little further involution. So what you have at that stage is what you're going to be left with. But remember, only 50% will involute satisfactorily.
So we have an eager Bella who's asking about her daughter who's got a venous malformation of the upper lip. She is asking about what her options are. What should she be concerned about medically and aesthetic repair? And we went over in detail her case before, and it's a VM beneath her upper lip. What is the best possible treatment?
Where does this child live?
Germany.
Okay, so they're very fortunate. There's a new treatment called bleomycin electrosclerotherapy. The acronym is BEST, bleomycin electrosclerotherapy. So, bleomycin electrosclerotherapy is very, very interesting. It is not available in the United States, and I believe it'll take some time before it becomes available. What has been found is that if an electric current is applied across an area and bleomycin is introduced into that area, the electric current will alter the cell membrane permeability to bleomycin, and the bleomycin will be absorbed one up to 1,000 times more effectively, and so the bleomycin will become much more effective. So it's simply two therapies, an electric shock and bleomycin. And this is usually done under anesthetic. So BEST is available in outside of the United States. It's available in Europe, and I travel to Athens, work with a team in Athens, and we do BEST routinely for patients with vascular lesions. But if this patient lives in Germany, the center for BEST is in Halle, and Volta Volgamuth is one of the principal protagonists of electrosclerotherapy, and he treats patients in Halle. So if you can get
Yes.
to him or anybody else doing that, that's a good therapy. Uh,
I think
yeah,
also that lip, first of all, venous malformations are one of the most common sites for venous malformations that we see. If it's just one isolated lesion, you don't need to do any other workup, but about 50% of venous malformations can be familial and not sporadic, as in just having one. In the States, the way we would approach lip VM is if it's just mucosal, meaning just superficial on the skin or inside the lip, we could do neodymium YAG laser. So that would treat the surface and some of the depth of it as well. And then the other treatment we can do either separately or in combination is using the same bleomycin as our traditional sclerotherapy, which is injecting it into the lesion without the electrical current. And then, of course, the third option is surgical debulking. So, but in each case, it depends on what the lesion looks like, how deep it is, how extensive it is. But those are the general options that we have, either separately or in conjunction, that we can offer patients here in New York.
and the results are exceptionally
Yes.
good. We can have these patients looking pretty much normal.
I think there was one question regarding multiple hemangiomas. And so if there are five or more, or we sort of take the number four, but five or more cutaneous hemangiomas on the body, so they're tiny, they're usually tiny pinpoint ones all over, then you need to do a workup for something called systemic hemangiomatosis, which means that there are many hemangiomas, and some of them can be actually inside the abdominal cavity, in the liver, in the viscera. So that means that you need to do more of a workup, and usually we get an abdominal ultrasound, and that looks at the liver and whether there are any hemangiomas in the liver. We then would treat that child with propranolol, beta blocker, and then monitor. We might, if there is a liver hemangioma, we would do another ultrasound in a month or two to follow up and make sure that it's shrinking. And then, of course, for the skin lesions, usually they resolve. Sometimes they're a little more prominent, more red, in which case we can always add some pulse dye laser to help those go away.
I see a question from Germany. The question is in German, and I'm just reading it about what can we do for a patient with an arteriovenous malformation in the right hand and arm, and we would be very happy to look at this patient and give some advice. I don't think we can provide adequate advice on this forum. We would have to look at photographs of the lesion, the MRI, angiogram, etc., etc. But they can contact us, and we'd be happy to help.
Are there any other hemangioma questions that you wanted
there are
to?
some coming across. There's one in general. It says, do any of these malformations cause a higher risk of being prone to having blood clots? And can these be inside the body as well, which I think you just touched on a bit.
I'm sorry. What was the
Can
question?
can they be prone to
Oh, you
forming
heard it.
blood clots? No. Um, Venous malformations do form blood clots. These are called phleboliths, and this is due to abnormal flow. These blood clots form locally within the venous malformation. They calcify eventually, but they do not travel. So they're not dangerous. They're not going to go where they're not supposed to go. But generally speaking, no. The answer is no. Um,
Should we talk about more venous malformations since you've gone into
Sure, we have a few
clotting?
questions from that as well.
So what Dr. Waner was alluding to is that when there's constant, there are veins, but the veins are abnormal, and so the blood flow in the vein is turbulent. It's not nice and smooth. It's turbulent. So in that turbulence, things precipitate out of the blood, and you can get phleboliths, which are, you can actually sometimes feel them. They're little calcified balls in the veins.
okay.
Okay.
Any other?
We have another venous malformation since we're on track with that. And this comes from Denora. And she asks that they've done sclerotherapy, removal of the malformation, and several laser treatments, but it came back. What next?
Where's a venous malformation?
Lower lip and cheek.
Okay, so one of the problems with venous malformations is that if you do not remove the entire lesion, that which you leave behind will continue to grow or expand. Now, the growth rate is slow, but they definitely will continue. So, for this reason, we should, when treating a venous malformation, attempt to address the entire lesion. We can remove whatever is necessary to make the patient look normal and function normally, and whatever is left behind will need to be treated with bleomycin, with bleomycin electrosclerotherapy, or some other form of treatment. So it is this is something that we do see, and obviously when we treat these lesions, we always follow the patient up, and we treat recurrences. So that's important.
So Lauren asks, again, venous malformation, doesn't describe where it is, age 2. Other than sirolimus, and it is a female by the way, other than sirolimus, is there any other medication available? If so, what are the pros and cons?
Oh, there are lots of. This is for venous
Venous
malformation.
malformation
Yeah,
in child age 2.
yeah.
Where is the venous malformation?
Did not give the location.
Oh, okay.
Okay, so
I
there.
think it's important to talk
Yeah.
about the extent of it and
Mm,
is medical therapy
yeah,
versus.
yeah. So what Dr. I was saying is that we're going to need to know how big this lesion is, exactly where it is, and from this we can determine what should be done. Sirolimus has become very popular, and one of the problems is if you have a hammer, everything looks like a nail. So if you're a surgeon, obviously you're going to want to operate on everything. If you're an interventional radiologist, well then everything should be embolized or sclerosed. And if you're a hematology oncologist, well then you're going to use one or other drug. I think that the most important is to select the most appropriate therapy for the patient and for the lesion. There are several drugs. Sirolimus is popular. There are several other drugs which are being used, alpelisib and several other VEGF inhibitors. And so we're just starting to see this generation of drugs become more and more popular. There are side effects of these drugs. Sirolimus has several side effects, and one of the side effects which people are not generally aware of is that it is possible for patients on sirolimus to have more difficulty conceiving pregnancy, both males and females, males in impregnation and females in becoming pregnant. Um, Although there are cases of people who've been on sirolimus who have fallen pregnant, this is a known side effect and has been published extensively.
But more commonly,
Yeah.
side effect would be something like mucositis.
Correct.
Or low white count, white blood cell count, something like that. But I think it's important to talk about where is the VM, how big is it, how extensive is it, because if it's localized, do you want to put a child or an adult on a medication that there isn't an endpoint to it necessarily? Um, I think sirolimus or these chemo agents are very good for, let's say it's involving the entire leg and pelvis, the thorax, airway, big, more diffuse, extensive disease would possibly warrant the medication. But if it's something local, something that we can really treat with some injection, some surgery, uh, our kind of overall philosophy is you do it and then you're done. You're not checking blood counts. You're not putting a child on an agent that we don't know what the long term effects are. Um, so just to kind of put it out there, but it has its role in extensive disease. It can decrease the volume of the lesion. It can decrease pain and help with function as well.
Yeah, that's very, very important. So I think the most important is that a multidisciplinary team should be involved in the management and all modalities should be considered and the most appropriate selected for the patient, keeping in mind things like side effects of these drugs and long-term benefits.
So mom replied that it's actually on her face, mouth, and neck with
This
the
is
location.
a venous malformation.
Yeah, venous malformation. How old is the patient?
2 years old.
Okay, so one of the questions that popped up is when do you decide to operate? When do you do laser treatment, etc., etc. Everything depends on the patient. Um, if uh, if a venous malformation is right on the surface, the skin is discolored, or the mucosa is discolored, and we can laser these lesions. We typically use a neodymium YAG laser. This can shrink the venous malformation, and we sometimes laser it first, and then which will shrink the skin, and then we can lift the skin up and remove the underlying venous malformation. So we do this frequently. We can sclerose it with some clotting agent before surgery to minimize blood loss. So we have all these tricks that we do. Our object is for the patient to look and function normally, to lead a normal life. and we do whatever is necessary for the patient to do that, whether it's laser treatment combined with surgery, sclerotherapy, or whatever is necessary. It's all related to that. So that's extremely important. So we have to consider the
So
yeah.
one of the questions is, does it stay away or does it come back? Uh, in areas where the anatomy is very delicate, where if we were just to go in there and cut everything out, you would have a big defect, and then another person may put in a free flap or have to move tissue in, and you won't get that sort of nice mouth opening, mouth function. We have to remember that these are benign vascular lesions. This is not cancer. So our goal is to deactivate whatever venous malformation is there, to remove and shrink it as much as possible so it's normal and everything looks normal, the stain, the coloring goes away. But there may be little bits and pieces sometimes just because it's so extensive, in which case you may follow it up with another bleomycin or sclerotherapy procedure. Everything may look great, and then maybe in 5 years there might be a small recurrence that doesn't necessarily need surgery. It may be a quick laser. So I think that's something to keep in mind, that we're talking about quality of life and looking normal.
There's a question here. When you surgically remove a venous
Yes.
malformation,
Yes.
yeah, will it come back? Does it stay away? And you answered that.
Yes, that's what I was trying to
Okay.
answer. I was trying to answer.
So
Would you
have,
change my
no,
we have
I'm
another
reading.
question over here
I'm
as
reading.
well. We
Yeah.
have a question from Michael. He's from Denmark. 6-year-old son. I'm going to paraphrase a little bit because there's a lot of info, but 6-year-old son with a VM above his left eye. He received 3 treatments with sclero, not electro. He responded well to the treatments, but needed them a bit more frequently than what the doctors prefer. Doctors prefer 1 to 0.5 years between treatments. However, now he's had 3 within 1.5 years. What are your thoughts on this? Is there any danger in receiving the treatments this often, and do you see any other options?
Well, if the child is requiring multiple sclerotherapies, is there any other treatment which could be given to this child? Could this child undergo surgical resection of the vascular malformation? I'm assuming it's a venous malformation.
Yes.
So
Where is it?
it's in the eye,
Upper eye.
upper eye.
Oh, upper
Yeah,
eye.
yeah.
Okay.
So this is something that we would need to see. We'd need to see the MRI. We'd need to see how extensive it is and if there is anything else. We don't typically do electrosclerotherapy in the orbit, in other words, around the eye, because we're concerned that the electric impulse might detach the retina or might affect the optic nerve or do some damage. So typically we don't do that. But if the child is requiring frequent treatments, is there anything else that can be done? Could surgery possibly be done? So these are things that we'd have
Which
to.
I think, which we can do.
Yeah.
Surgery on the upper eyelid venous malformation is possible and can be done.
Now, there is a question here, are multiple best treatments required to treat an AVM? Typically, bleomycin electrosclerotherapy is not a single treatment. It's not one treatment and you're done. It frequently involves more than one treatment. Now, it's not typically used to treat arteriovenous malformations, although 1 or 2 people have reported success, and I would imagine more than one treatment is necessary to treat an AVM successfully, if indeed that is possible. Do you have any other questions?
Yep. So we have Jelena, and this is regarding a venous malformation of the face cheek. How safe is sclerotherapy on the face/cheek considering its closeness to the brain?
Okay.
She has a 2-part. Sorry.
Yeah.
Slow flow venous malformations of the face and pregnancy. what to expect.
Okay, so concerning sclerotherapy, obviously this depends on the experience of the interventional radiologist. You obviously must go to an experienced interventional radiologist. A lot depends on the agent that is being used.
The location,
The
it's being injected.
correct.
You know, this area here, the veins that go into the face go straight back to the brain. So right in this area, they'd have to be careful. Some sclerosants are thicker and don't just fly into the bloodstream.
Circulation, yeah.
Circulation, like for example, something like onyx, which we don't use for venous malformations, but do use for AVMs. And then sometimes they add other medications within. So as Dr. Waner said, very important to go to an interventional radiologist who does this all the time, who's also head and neck trained, so able to go into the brain. And
Is
there's some,
experienced, yeah.
something else I want to say
Now,
about sclero.
yes, so there can be unintended
Yeah.
consequences. For instance, the sclerosant can go where it's not meant to go. Today we saw a patient who'd been treated elsewhere with a sclerosant
Yes.
for an arteriovenous malformation who had very severe unintended consequences. This was a facial lesion. So the experience of the person is very, very important, and this will prevent complications. Yeah.
We have a bunch of questions on port wine, so
Yeah.
I think we should move a little bit
Yeah.
further. Melissa is asking, port wine stain of the leg, which covers all backside of the leg of 4 months old. Should it be treated now or better to wait? And are there any other treatments than laser?
Okay.
Go ahead.
This is a this is a favorite debating question. You know, when should we treat? There are people who claim that it's best to wait. There are others who claim that early treatment is far more beneficial. And in fact, there have been multiple research papers on this. What do I believe? I believe that early treatment is beneficial, and I believe that the first treatment of a port wine stain is probably the most beneficial, and especially if it's done at an early age. So, how old is the patient?
4 months.
4 months. Yeah, I would definitely start now. There's no advantage to waiting, and so I would start soon after it's diagnosed and as soon as it is safe to do so. I'm a believer that laser treatment should be done under anesthetic because I believe it's extremely painful, and I don't tolerate pain very well, neither in myself nor in any of my patients.
Yeah.
So I prefer to do laser treatment under anesthetic. It is extremely painful. You know, any parent should try it out. One or two pulses are not that bad, but
No, one
continuous
pulse is bad. I tried it on my leg and it
continuing,
really
well, she's a
stings.
bit of a wuss, but
It stinks.
continuing
Yeah.
pulses is extremely painful. You know, we had a patient who had multiple treatments without anesthesia and had post-traumatic stress. Just merely mentioning laser would put her into a bit of a state. So it is painful. So the answer to that question is yes, I would treat. I would start treating now, and I do believe that this patient should seek somebody who offers treatment under anesthetic, especially for such an extensive lesion.
So
And
that
it's
patient,
quick. The anesthesia is a gas, a quick mask. Zap, zap, as many zapping, and then wake up and go
15,
home.
yeah, 15, 20 minutes.
so
Yeah.
that patient, I believe, is from the UK. That makes a difference.
Well, yeah, you know, you should look
Maybe,
around for somebody who does laser treatment, especially somebody who does it under anesthetic. It's much more kind and much less traumatic.
So the next question, we're sticking with the port wine, is from Kathleen. She has a 9-month-old baby boy who's had 23 pulse dye laser treatments.
Wow.
Fine. So
How would
3 a month.
you suggest moving forward?
Well,
I'm sorry, it's of the V2 distribution of the face.
So it's a
yeah,
mid cheek.
mid cheek. Okay. If I can be
So much.
blunt, if this many laser treatments have not produced maximum lightening, then
That's almost once every 1.5 weeks.
yeah,
You
that's very
barely
frequent.
recover.
Yeah.
The
There's
skin has barely recovered.
Okay, so our philosophy with regard to treatment of port wine stains is as follows. We provide treatment until maximum lightening has been obtained. In other words, until the port wine stain is no longer lightening from subsequent treatments. Once that has been achieved, that's your maximum. That's about as light as it can get. Treating more than that is not going to produce more lightening. So once you've reached that, then you go into maintenance treatment. You realize that this is about as light as it can go, and then you provide treatment every 6 months or every year or every 2 years. What we do is we wait to see whether or not the port wine stain is going to begin to darken again, and if it does so, we provide one or two treatments to get it to its maximum lightened phase. Uh, we
In the
cannot, yeah, they're
the
very,
first year of
yeah,
treatment,
yeah,
we generally say about 6 to 10 treatments in the first year of treatment, and then going into maintenance mode.
yeah. But we don't like, you know, our philosophy is that we don't treat every 2 or 3 weeks because we feel that this is too much, and we feel that the port wine stain hasn't even recovered from the previous treatment. So that's our modus, and that's the way we do it. We typically treat every 6 to 8 weeks, sometimes every 3 months. We're a little more conservative when it comes to that. But you continue treating until you get maximum lightening, whether that is complete disappearance or very faint residual port wine stain. You then stop and wait to see how long it takes to re-darken, and then provide treatment to keep it at its maximum, uh, most light uh, phase. And that's pretty much what it is. So if this patient has had so many treatments and still has a port wine stain, I don't think additional treatments are going to provide any further relief or any further improvement. Um, is there anything else that can be done? At this stage, unfortunately not.
Not
Depending
under
on where the port
PDT.
wine stain, sorry, uh,
Um,
what did you say?
well, in the U.S., pulse dye laser is the standard of care. That's the laser that everyone uses.
Yeah.
But there is another treatment called photodynamic therapy, which is used in China. We don't. Do you know anyone doing it
I
here?
don't think there's
No.
anyone in the States doing it, no. But, it may be of,
It's quite effective. It maybe takes one of those treatments, may do the effect of 3 or 4 pulse dye laser treatments, but because of the product that they put in your vein, you have to be in a dark room for a month,
yeah,
which no kid or even human wants to be. So,
yeah,
because you get photosensitivity, and therefore they're kept in a dark room for a month.
yeah. But at this point, there is no other treatment for port wine stains. Perhaps one day we'll find something better.
So Macy asks, after the laser for port wine, does the pain continue?
Yes, for a little while, it feels like a bad sunburn. So
Probably
it's
just what,
in,
like a few hours.
yeah, a few hours.
Yeah.
Yeah, it's intensely painful and very, very painful
It
during the treatment.
stings. Yeah.
And afterwards, it feels like a bad sunburn. So We typically ask the parents to give Tylenol. Tylenol should be fine. We prefer not to give um, a
Motrin.
Motrin or anything like that because of its antiplatelet activity. So Tylenol is good.
So we have Amy on. We have a few people asking this, but Amy was the most recent. If her child had a hemangioma, what's the likelihood that her child's child would? And along the same lines,
Yeah.
they're being asked about other malformations. How can you prevent through another pregnancy having another child?
Regarding infantile hemangiomas, there's no known genetic component to this or heritability. It really is, the statistics are that 1 in 10 kids is born with a hemangioma. It's more common in Caucasian fair skinned people, but it can occur in all skin types. Regarding some of the other vascular malformations, venous malformations, 50% can be genetic and 50% isolated. Lymphatic malformations, there's no genetic predisposition. And AVMs can be genetic if they're part of something called HHT, or hereditary hemorrhagic telangiectasia. So different AVMs can be part of another genetic disorder, but those are rare. And what else?
Well, there are
Glomovine.
conditions.
Oh, the other
Glomovine,
kinds of
yeah,
venous malformation, and you can talk about
yeah.
that.
Glomovenous malformation is hereditary. It's an autosomal dominant inheritance, and blue rubber bleb nevus syndrome, which is also in the family of venous malformations, is inherited. Remember one thing: venous malformation is this basket of several conditions made up of abnormal veins, some of which are inherited and some of which are not. And the two that I'd mentioned are inherited, but for the most part, just a typical venous malformation is not inherited. We've got a lot of questions.
Yeah.
Now we're going to go
Fine.
through these, and we're going to respond to each of the people who've sent these questions if we don't get through them, which we're not going to.
Right. So as long as they provide their email
Yeah.
through our Ask the Experts, we will respond. The UK is asking, do you travel to the UK?
I love traveling to the UK, and I do have a British license, although it's inactive at the moment because I don't practice there. But I am working with a very good interventional radiologist in London to try and set up a clinic in the UK and work together with doctors in the UK to treat patients. Once again, I do have an inactive UK license, and I would love to come to the UK. So at this point, no, but at some point in the future, that may well be possible.
There's been quite a few questions sprinkled through. It's might not be something for you to respond to, but do we uh, participate or take insurance? And do we work with any foundations?
Okay.
I'm
Doc,
Yeah.
happy.
yeah.
Yeah.
Well,
Go ahead. You want to answer?
Dr.
Yeah,
O
go.
takes Blue
Yeah.
Cross Blue Shield. I'm out of network, but as Michelle will tell you, we work with every insurance. We're able to obtain special exceptions. Do you want to elaborate on
Um,
this?
yeah, actually, yeah. So we do. We work with insurances across the board, and we never let finances of treatment of your child be an obstacle in their care, ever. We have a strong team, and we find a way. We work together with you, so please don't let that discourage you from reaching out. You can ask many of the people on the site and the forum right now how we've worked with them and how seamless we make the process of coming here.
Yeah, we also have a foundation, and we also work with several foundations that are aligned with our missions.
Yeah. Any
Yeah.
other questions? Yeah.
I
Just
think a lot of them are repetitive.
Yeah.
One,
So,
yeah, it looks a lot
yeah.
repetitive.
Thank you very much. If there are any more questions afterwards, if you think of something, you can email us through the website and we'll be happy to respond by email. I think we're.
We will
wanna
be,
finish
this
up?
is recorded, it will be posted, and we are going to work diligently.
Oh, there is one. What do you expect in pregnancy? And I think this
Yeah.
relates into a
Well,
venous malformation.
yeah.
Yeah. Did you want to answer
Yeah, so all vascular malformations continue to grow through your lifetime, from birth to death. So, but there are times in your life where they may get bigger, and those are changes in hormones. So, puberty would be an increase in the size of a venous malformation. Pregnancy would be another one. So, you could expect that the vascular malformation that you have may become more active, may become a little more swollen, may become a little more painful with pregnancy.
And there's one more. Is best more effective than ethanol sclerotherapy for VM
That's a
of
good
the upper lip?
question.
That's very good. You know, I would say, first of all, ethanol is dangerous. Depends on who's providing the ethanol sclerotherapy, but there are lots of complications associated with ethanol. If the interventional radiologist has incredible experience in the use of ethanol, that's fine. Is best more effective? I can't say. There's never been a side by side comparison, but I have seen phenomenal results of venous malformation of the upper lip after treatment with BEST. And
I think
somebody,
it's safer.
yeah, it's definitely
Yeah,
safer.
alcohol sclerotherapy, depending on the concentration, how it's injected, can actually cause uh,
Problems.
problems with heart, lungs, and even lead to death. So it's very important to go to somebody who does it all the time and has tons of experience using alcohol if you do. In our center and the people we work with here, we don't use it because of that little window of problems that you can encounter. Best, on the other hand, uses bleomycin. The electrical current that's set up between the little probes actually makes the cells more permeable. So you have a cell on the vessel wall, and the electric current makes those openings. There's those gradients between the outside of a cell and inside of a cell. It makes it more permeable, so then the medication can go right into the cell. So we may use, I don't know, 6 milliliters of medication with BEST. That dose is a fraction of the dose that we might use with direct sclerotherapy. So that's one of the differences. You use much less drug and it's much more effective because the electrical current sets things up.
Okay, we've
Okay.
reached 4:59.
Yeah,
Do you
so
want to
we
wrap
do
up?
have, I just got the green light. One of our patients from our group could not be live. She wanted to announce the breaking news that special edition reporters just wrapped up filming her and her family, a 9-month-old baby with a hemangioma. And they will be filming Dr. Waner and Dr. O on this case next week in and out of the OR. So that'll be on prime time media internationally as well as nationally, and we'll keep you posted as to when that's going to air. And you can look out for that family. Will be following their journey very closely as well.
Okay, and we will provide another Facebook Live session.
Yep, we have the date.
Okay.
So we're saving the date for the next Facebook Live will be on May 22nd. Eastern Standard Time is 3:30. And we will send out invites as well as the registration forms. We'll also wrap up everything from today and get back to all of you.
And we will try and answer all of these questions that have been posted. It's just not been possible to answer all of them, but we will go through all of them.
So thank you so much.
And
Thank you for
thank
your
you,
questions.
Michelle.
I thought
And
they were really important.
yeah.
Some of the ones that we hear all the time. So it's good to get them out there and the answers. So thank you so
Yes.
much.